journey to unravel the mysteries of a highly significant oral pathology, the ameloblastoma. If you're involved in oral health or pathology, you already know this name carries some serious weight. I mean, excluding odontomas, its incidence is literally equal to all other odontogenic neoplasms combined. Today, we're breaking down exactly why it is the most significant odontogenic neoplasm we face, using the evidence right in front of us.
Okay, let's dive right in by asking a pretty fundamental question. What actually happens when the tissue meant to build our teeth forms a persistent tumor instead? Think about it. The tissues designed to create our dental enamel, which is this incredibly hard, precise structure, suddenly take a totally different neoplastic path. The results are complex and, frankly, kind of deceptive.
Here's our roadmap for today. We'll start with the origin of the tumor, check out the clinical and radiographic clues, break down the 3 clinical types, explore the histologic subtypes, and finally, wrap up with our treatment strategy.
All right, Section 1, the origin of the tumor.
By definition, an ameloblastoma is a true neoplasm, a tumor originating from enamel organ-type tissue. But here is the fascinating catch. It never actually undergoes differentiation to the point of forming any hard enamel itself. Fun fact, they originally coined the term adamantinoma back in 1885, implying hard tissue formation, but since there isn't any, it got corrected to ameloblastoma in 1934. It's literally a tumor of enamel-making cells that stubbornly refuses to make enamel.
And this classic description by Robinson perfectly captures its deceptive nature. He called it usually unicentric, non-functional, intermittent in growth, anatomically benign, and clinically persistent. It's that last part, right? Anatomically benign and clinically persistent. That completely defines the clinical headache it causes. It might lack the cytological features of a frank malignancy, but its relentless persistence and local invasiveness make it an absolutely formidable challenge.
Moving on to Section 2, clinical and radiographic clues. Let's look closely at the clinical features of ameloblastoma.
Location is our first major clue here. A staggering 80% of all ameloblastoma cases occur in the mandible, and within the mandible itself, the molar angle ramus area is involved 3 times more commonly than the premolar and anterior regions combined. So if you see a suspicious lesion in that posterior lower jaw, ameloblastoma should immediately jump right to the top of your differential diagnosis.
When examining patients coming into the clinic, we typically see them presenting between the ages of 30 and 50. They'll often come in with this bony, hard swelling that actually causes noticeable facial asymmetry. And that asymmetry is a massive physical clue. Because these lesions are locally invasive, they can infiltrate the medullary spaces and erode cortical bone. In larger, more advanced lesions, patients might even report mobile teeth, pain, or paresthesia. That tells us the tumor is actively encroaching on local nerves and tooth roots.
Now, looking at the radiography of ameloblastoma, check out this classic multilocular cyst-like lesion. Notice that compartmented soap bubble appearance? The tumor exhibits this look with septa of bone extending right into the radiolucent tumor mass. Sure, some cases can just be unilocular and lack specific features, but this bone destruction and soap bubble pattern? It's an absolute hallmark of advanced ameloblastoma. It's visually striking, you really can't miss it. Okay, Section 3, the 3 clinical types. Let's explore the clinical types of ameloblastoma.
The current World Health Organization classification divides them into 3 main categories: the solid or multicystic type, the unicystic type, and the extraosseous or peripheral type. Categorizing them like this isn't just a dry textbook exercise. It actually dictates how the tumor behaves in the patient's jaw and directly informs our next clinical steps.
Which brings us to Section 4, exploring histologic subtypes. Time to dive into the histology of ameloblastoma.
When examining this under a microscope, our source material recognizes 6 primary subtypes. We've got follicular, plexiform, acanthomatous, granular cell, basal cell, and desmoplastic. Identifying these is absolutely critical. While you might see combinations of different patterns in a single lesion, the predominant histologic subtype we identify has serious real-world prognostic implications for the patient's risk of recurrence.
Let's compare these side by side so you can see exactly what I mean. Over on the left, we have the most common variant, the follicular type. Notice the discrete islands of tumor cells with those tall columnar cells on the periphery. They look a lot like preamyloblasts, enclosing a central mass of loosely arranged cells resembling the stellate reticulum. Now, jump over to the images on the right, showcasing the plexiform and acanthomatous variations. In the plexiform type, instead of those discrete islands, you see irregular masses or this complex network of interconnecting strands of cells. It's a completely different architectural pattern. Now here is a rarely encountered but visually fascinating variant, the desmoplastic ameloblastoma. Notice how the dense, hyalinized collagenous stroma literally squeezes the tumor cells. It forces them into these stretched out, thin strands and cords that give it a distinctive kite tail appearance. The central cells are scant, and unlike the follicular type, the peripheral cells here are flattened or cuboidal rather than tall columnar. It's just a wild visual difference driven entirely by that dense stroma.
We also really need to look out for specific growth patterns in unicystic types, like the mural growth, seen here. Look closely at how the ameloblastoma epithelium doesn't just line the cyst. Invasive islands of the tumor are aggressively infiltrating deep into the connective tissue wall. As we'll see in just a second, spotting this mural invasion is a major turning point for how we manage the patient.
So what does this all mean? Why does distinguishing these tiny cellular differences matter so much? Well, just look at these numbers. The follicular type carries a recurrence rate of nearly 30%. Contrast that with the acanthomatous type, which shows only a 4.5% recurrence rate. The plexiform sits right in the middle at around 16.7%. So the cellular architecture completely alters our understanding of the tumor's aggression, and it directly dictates our surgical approach.
And that leads us perfectly into Section 5, Treatment Strategy. Let's talk about the treatment of ameloblastoma.
Because of the varying aggression we just explored, our treatment has to be highly strategic. First, we assess the location. The cancellous bone of the maxilla facilitates spread, whereas the dense cortical plates of the mandible can actually limit it. Next, we tailor the surgery. There's general agreement to use conservative treatment, like curettage, for simple luminal or intraluminal unicystic variants. But, and this is a big but, if we spot that mural variant we saw earlier, or if we're dealing with a conventional solid type, we absolutely must perform radical surgical excision, because it acts with the exact same biological aggressiveness. And finally, regardless of the treatment form, mandating strict, long-term follow-up is an absolute necessity to catch those persistent recurrences.
As we wrap up this explainer, consider the genetic mysteries we are just now beginning to uncover. The source texts note that amyloblastomas with SMO mutations tend to be seen in the maxilla, while those with BRAF mutations are found in the mandible. While this genetic dichotomy is still a bit unclear, it leaves us with a really compelling question. With emerging clues like these mutations, what secrets will we unlock next? How might future genetic-targeted therapies completely change the way we fight this persistent tumor? Thank you so much for joining me on this diagnostic journey today.